see everybody. I've got my mask on to record these unprecedented times and encourage everybody to be as safe and vigilant as possible to keep COVID-19 at bay as we enter the holiday season. Thanks to everybody for joining. Wanted to open up our meeting today with a review of the minutes from our September meeting. So those were sent out, and I'd like to have a motion, please, to approve those minutes or open comment for them. Hearing no comment, I'd like to ask Bobby to make a motion to approve those.
I don't know that Bobby's on yet.
So another commissioner member, please.
So moved. Tamara here. So moved.
All in favor?
And I'll second that motion to approve the minute.
Thank you. So we have a motion. It's seconded. I'd like our general counsel to call roll call, please.
We'll start with the chair.
Approved.
Commissioner Sullivan.
Aye.
Designee Williams. Commissioner Choate.
Approved.
Commissioner Davis.
Yes.
Commissioner Murphy Rodriguez.
Yes.
Designee Butler.
Yes.
Commissioner Clenard.
Yes.
Commissioner Gentile.
Approved.
Commissioner Jennings.
Yes.
Commissioner Sinenko.
Approved.
And Commissioner Timothy Sullivan.
Yes.
I think that's everybody I have.
You missed me, Andrew.
Who did I miss?
Adam Chapdelaine.
Oh, I'm sorry, Adam. I didn't realize you had joined. Commissioner Chapdelaine.
Yes.
All right. It is unanimous.
Thank you. So today we have a very full agenda with lots of interesting information. So at this point, I'm going to pass it on to our executive director to give you an overview of so much that's happening, and as we prepare for next year's rate setting and all the work that's needed on an annual basis to keep our members in their insurance. So good morning, Matt.
Thank you, Madam Chair. Can everybody hear me okay?
Yes.
Great. So welcome. I want to welcome everybody to our November commission meeting. I believe it's our 4th virtual commission meeting since we started doing these in the spring. And thank you all, commissioners, for joining us on Zoom, and for members of the public and stakeholders joining us as we live stream on YouTube. And I wanted to start briefly with just a brief intro, which is just to acknowledge what's happening all around us in this country and here in the Commonwealth with the resurgence of the COVID-19 virus. I hope you all and all of your loved ones are healthy and safe. And I also want to recognize the ongoing work of Governor Baker, Lieutenant Governor Polito, Secretary Sutters, of course, who's heading up the command center, and all the staff at the command center. Thank them for all the work that they're doing, and all of our healthcare leaders, as well as frontline healthcare workers and first responders. I think the good news is, if there is good news here, is that the healthcare system in Massachusetts is in a much stronger position to meet the challenges that the virus will pose to us for the months ahead. The goal of the command center has been and continues to be maintaining access to care, needed care, whether it's for COVID-19 related treatment or otherwise. I'm I'm happy to say that what I'm hearing generally is that we are well prepared. I would not want to miss the opportunity just to emphasize the importance to everyone that's listening to continue to follow the public health guidelines that relate to COVID, the importance of social distancing, hand washing, and wearing a mask at all times that you possibly can. Of course, this is especially important as we head into the holidays. I know it'll be the first time that I haven't gone to my mother's house for Thanksgiving in a long, long time. And it makes us all sad that we can't do that. But as others have said, it's probably the most effective act of Thanksgiving and love for those around you to not gather outside of your immediate household. So I don't want to miss the opportunity to just express the importance there. I also just want to acknowledge other leaders and other rank and file workers across state government and municipal government. I'm daily amazed at how well my team has performed here since we went into this unusual condition, but also the degree of collaboration across state government, and just the dedication and diligence of those who serve the public. It really is a time for public service to shine, and it shines in ways that I think a lot of people don't necessarily see. So I just want to acknowledge my team and everyone else across state and municipal government who are helping us get through this crisis. So our first item, formal item in the director's report is the calendar. So Janine, if you can go to the calendar
goody.
slide. Oh, I'm sorry, we got to do minutes.
Sorry.
And we've done minutes.
Yeah, so we've already approved the minutes,
Yep.
and
So-
I just want to acknowledge that Bobby and
Finally.
a few other of our commissioners had trouble getting in, so we hope you're in now.
Yep.
So thank you.
Sorry.
So
Thank
good
you for
morning,
joining us.
Vice Chair Bobby Kaplan. And I think Eileen McEnany got on.
Good morning.
Good
Hello.
morning.
So go ahead, Matt.
Thank you, Janine.
Walk through the agenda.
Yep, so for the director's report, we'll start off with the calendar. So Janine, if you can go to the next slide for the calendar. We've taken a little different approach with the calendar here. It's a busy calendar because we are busy and we have a busy time ahead over the next several months. But I wanted to, in addition to illustrating kind of where we've been recently on some of these topics as a commission, to also highlight what we're doing today, but what the coming several months include. So you'll note in the new purple squares up at the top, we will be beginning at our next meeting a series of conversations and presentations about FY22 rates and any potential plan design changes. And we do that as we always do over the course of 4 meetings. We have already ongoing preparation for next spring's annual enrollment period. I have it on the slide here for our February and March meetings. As you know, we're likely to have more conversations with you at the commission about that work, but there is already substantial work going on internally here to prepare for that. Of course, we are very much expecting that it will be again a largely virtual process in terms of all of our normal activities surrounding annual enrollment. So I wanted to note that. We have several procurements. We have 2 major procurements, dental and vision and Life and LTD, which we will update you on briefly today, but we expect to have votes for you, actually probably votes for both of those procurements for approval at our December meeting. I had them here for December and January, but we're actually running a little bit ahead. So, we will have more for you on that. And then just to note, our listening sessions here in the dark blue that are always an important complement to the work that we do at the Commission around rates and plan design changes. Again, those activities this year will be remote. We'll be talking about that in a moment in the other parts of the director's report about how we're thinking about that. But we're starting to plan that. Go ahead.
If you would just speak a little bit about, what you know about the public listening session, so we know they'll be remote. Will there be support for our members to be able to log on and record these so they can listen, if they're not able to, have a live, and you might not know that now, but I think this would be important for us to get out. I know we always get asked for as much notice to get this information to our constituents. So I know you're working on it, lots going on. I'm sure you're on it.
Yep. We actually have that under the engagement section of the director's report, so we'll get to that, some of those details in a moment. Just the last thing to note on this, well, last two things. We have, in the midst of all this work, we are also continuing to move forward on our modernization, internal modernization efforts. And we'll have a really exciting presentation for you, I believe, at the December meeting. One of the three main strategic priorities of the Commission, you will all know, is our efforts to modernize our operations, but also to enhance the members' experience, really to transform the members' experience. And we're making some significant headway in that regard. So it's a really exciting project, and we'll have more for you in December on that. We will have the out-of-pocket report in, I believe, the January meeting. And I think, and the plan audit, which we were hoping to have for you at this meeting, needs a little bit more time, so we'll be doing that in January. So there's a lot going on. I also note at the bottom here, stakeholder engagement meetings. Again, I'll be talking a little bit about that in a moment, but those will be ongoing. We've got a lot of internal work there that is happening now, but we expect to be having external facing engagement meetings as soon as next month. Any questions on the calendar before I dig into a few of these items?
I don't see any hand raises, so you may move on.
Okay. You can go back to the director's report agenda. Perfect. Thank you. Let me start with a legislative report. The House of Representatives, start with the budget, the FY22 budget. Of course, it has been an extraordinary year for budget preparation and development, which we would typically have in place back in July. We are now, due to COVID challenges, well into November. But there is a great deal of work that's being done here. The House of Representatives approved their budget for fiscal year 2021 back on November 12th. The House funded the GIC line at the same level as recommended by the governor in his revised budget proposal. So we're thankful for that and appreciative. As of this writing, the Senate has not yet completed work on its budget, but they have been marching through amendments as recently as yesterday, and probably will continue today. So that work will continue. The governor has expressed his desire to have a a budget on his desk by Thanksgiving, which certainly seems in reach, or thereabouts Thanksgiving. As we've updated you at a prior meeting, there are healthcare bills covering a number of different topics that do implicate the GIC in a few areas. Telemedicine is one important one, surprise billing, behavioral health, and those continue to be negotiated in conference committee in the legislature. On the municipal side, the municipal portfolio remains steady. We do not anticipate any departures of municipalities this year. By statute, they have until December 1st of each year to inform the GIC in writing that they wish to do so, and we have no signs of that as yet. That's the legislative report. Glad to take questions if there are any. Seeing none.
I see none. You
Okay.
can-
Onto the human resources report, which I'll hand over to Brock Weidenheimer, our HR director, in a moment. But I did want to start with a little piece of, not a little piece, it's actually a big piece of exciting news on the HR front, and about a recognition of some of our staff. So commissioners will recall that last fall and into the winter, we stood up My GIC link, which was a really important first phase of our modernization efforts, and allows, it actually replaces a lot of paper-based manual processes that sort of are forms coming in the mail, and we've transformed a lot of those functions into an online portal that our partner agencies and municipalities can use to process those transactions. We've gotten tremendously positive feedback on that new capability, and it's hard for me to imagine how we would have survived the transition to remote work, and on our part and the part of all of our partner agencies, without that tool in place. And sometimes this work, again, is the kind of work that goes unacknowledged, but I'm happy to say that the My GIC link implementation team, which is a team that includes both GIC and A&F staff, were awarded the Commonwealth of Massachusetts 2020 citation for outstanding performance.
Wow. Terrific.
So I'll tell you a little bit about it. This team was under the leadership of Paul Murphy, John Harney, Robin Healy, and Stephanie Sutliff. And team members included Donna Wortman, Nick Vogler, Chuck O'Brien, John Williamson, Stephen Gerard, Joan Matsumoto, Jim Rust, and Brock Weidenheimer. And I'm just supremely proud of them for the work that they've done. So I wanted to acknowledge that.
Yeah.
I see some muted hand clapping, which is well-deserved. With that, I'll hand it over to Valerie. Yes. Oh, that's a clap. I thought it was a raised hand. Okay,
Yeah.
good.
No, I think there should be a pause for some clapping, because it was a really great effort. And I know that it helped tremendously keep our members engaged through open enrollment despite COVID, and such a time for needing your health insurance, and the GIC was there. So it was really great.
Mhm.
So, and I know Eileen has her hand up now, maybe also clapping.
I definitely was clapping, and I just want to say congratulations. I think it's important to recognize certainly the good work that was done by the team, but I think more importantly, as Matt, you have indicated, it allows the GIC to operate in this environment, and I think it just accelerated a positive change in a way that probably wouldn't have been possible. So great job, everyone.
Yeah, thanks Eileen.
Thank you, Eileen.
All right. You can proceed, Matt.
Okay,
Everyone joined in clapping.
thank you. So we'll hand it over to Brock for a few updates on the human resources front.
Great. No, thanks, Matt, and good morning, everybody. Really wanted to give a quick update about some changes in our recruiting and onboarding programs in light of the workforce working remotely. Both our current workforce, but also people that we're hiring are coming in on a remote basis. So we had paused our recruiting activity entirely for a period of time back in March when we were helping focus our attention on supporting employees as they adjusted to working from their homes. But we have now resumed recruiting, and we've developed new programs where the interviews are entirely conducted via Zoom and using other remote technologies. It seems to be going well. We've hired 3 new employees who have started over the past couple of months in our operations group. We have another offer that was just accepted for another employee who will start in operations in early December, and we have additional recruiting ongoing now. So it's different, but it seems to be going going well. And like everything else, people are getting more and more accustomed to seeing each other on video screens rather than in person. And then we've also developed new onboarding programs to support new employees who will be beginning their careers with the GIC working from their homes rather than in the office. And that includes both the administrative sides of onboarding, making sure we get all of the benefit enrollments and I-9 forms and the like completed. But more importantly, we've changed the way we're doing the operational aspects of onboarding, and making sure we're helping employees learn their new roles and setting them up to succeed. And again, the employees who have started have all been in the operations group, and onboarding there typically is based heavily on shadowing existing employees and sitting and observing them and learning from them. So in the current environment, we're mimicking that as best we can, using Teams, using Zoom, and so that we're still able to largely replicate that, having very frequent check-ins between the new employees and their supervisors, which has also been very helpful. We have asked the new employees and their supervisors to come into the office in person on the first day that the employee starts work. And that's been the only day we've asked them to come in. But on that first day, that provides an opportunity for the supervisor and the employee to meet in person, to talk about the role, set expectations and the like, and also gives an opportunity for the person to pick up laptops, other equipment and supplies that they'll be needing, and to complete some of the paperwork we talked about. But beyond that, unless there are kind of unique project-based required needs for someone to come in, excuse me, the work really is entirely remotely, and the onboarding is taking place remotely. So far it's going quite well, and we'll continue to learn from the experience and to take input in from the supervisors and new employees, and I'm sure make adjustments as we go forward. But we just wanted to let you know that we are kind of back bringing in new people and helping them acclimate. And then on a related note, I just wanted to quickly touch base on some training programs that we've been providing to employees, again, to help them to kind of adjust and acclimate to the teleworking environment. We, in partnership with HRD, had two separate training programs rolled out through LinkedIn Learning, online programs, one module for management employees and one for non-management employees. And all of the employees at the GIC took part in those. The management training program focused on managing remote employees, managing remote teams, and leading virtual meetings. And then for the non-management employees, there was a module called Making Telework Work, again through LinkedIn. And it focused on successful foundations for telework and effective time management while working remotely. And then in addition, the GIC developed a training program of our own in conjunction with the Mass for You EAP program that we conducted for managers and supervisors on managing remote teams. That we did that a couple of months ago as well. So we'll continue to partner with HRD and look for opportunities on our own to make sure people are receiving any support and training that's helpful to them. And just wanted to give this quick update to the commission now.
Thank you, Brock.
Do we have any comments?
I can't find my chat. Sorry. I don't know where
Bobby
it
has
went.
a comment.
Yes, I do. So I'm just raising my hand. So I just wanted to congratulate Brock and the HR team, because I think it's amazing in this environment during the time of COVID that you are hiring, that you're able to onboard people, that people are then they then go home and they're actually performing the job. And it's not an easy job, right? Particularly now, where so many people are reaching out and calling about their health insurance and their benefits and what's covered and what's not covered. And I'm sure you're now going to be receiving lots of calls regarding reimbursement for the vaccine, like who's paying, because I'm quite sure those calls will be coming in very soon. And I just want to say from how much we appreciate the work you've done with my GIC as well, and how quickly everyone at GIC has just come together and rolled this out for all state employees and the retarees. You've all done an amazing job, and I just wanted to say thanks.
Well, thank you, Bobby. It's a nice confirmation of just the caliber of people we have across the GIC at every position, that it's gone as smoothly as it has. So thank you.
Thank you for that, Bobby. Really appreciate that.
Great.
So move on to the next item here, which we have under engagement, a kind of general description here. But I more than anything, I wanted to just inform the commission that the work that Denise Donnelly and I walked through at the September commission meeting is ongoing, that our lead up to the next procurement for FY24 will include a robust strategy to engage with a variety of internal and external stakeholders. And we look forward to really launching the external facing part of that work very soon. So I wanted to just assure folks that that work continues. In that context, I believe at the September meeting also discussed a conjoint survey, which under our kind of prior timeline had planned to launch already by this time, but we wanted to take a bit of a pause on that and to move forward with some of the more general engagement discussions with our stakeholders before we proceed with that survey. Among other things, it'll help us to refine our strategy for the survey, and we want it to be most helpful and provide the most useful insights for us as we go forward into the procurement. So we do expect to proceed with the survey probably in our Q3 or the first quarter of the calendar year, I guess, but our Q3 in fiscal year. So more to come on that. Listening sessions, Valerie, you had wanted us to talk a little bit more about that, and we certainly have been thinking about it. We'd had an extensive internal conversation actually yesterday on this topic, and we're interested in feedback from the commission both today and after the meeting. So I would say, first of all, we fully expect it to be remote. which presents challenges, but also presents some opportunities, right? So what we have at the Commission's direction done in the past was to have our in-person listening sessions in a variety of places across the state so that we could get geographic reach as much as we can. Of course, we can't do that now, but it also means all of the logistical work of lining up locations for those, staffing them, and all the site preparation we won't have to do. So we're thinking about, so it will be virtual, and we're trying to think about what's the correlate to that geographic diversity in a virtual setting. So we're imagining we want to do several virtual sessions. We can decide how many. We haven't determined how many. I would imagine we'd want to do them at different times of the day or evening for folks who work during the day or have time during the day. We probably don't want to put them all in one week, but maybe spread them out over a little bit of time so that someone who's not available in any one week would miss that. We will, as we committed to last year, provide the deck and materials ahead of the meeting so that folks have an opportunity to go through that, and FAQs, which we did last year. Sometimes I think people just want to see what's on it to decide whether they want to take the time to come to the actual listening session. So we want to provide that opportunity. And, you know, in addition to talking generally about the challenges that we face, cost challenges and other challenges, and talk about kind of rate development and any potential plan design changes, we also want to use this as an opportunity in the engagement framework to have other discussions as well. We want to put on people's radar that we are beginning this early work that will lead up to the next procurement. So we want people to understand that that work has begun and describe our efforts to engage with our stakeholders going forward. But I think even more immediately, talking about the coming annual enrollment period in an age of COVID, what is that going to look like? So we want to both describe to people what we're thinking about these various items, but also to gather as much feedback to inform that work going forward. Among the sort of questions that were raised that we're going to spend more time thinking through is whether we might even be able to put together sessions that are tailored for a particular audience. You know, a presentation around retirees specifically might give us an opportunity to spend more time on retiree issues and less on issues that don't relate to retirees. I'd say the same for labor. Maybe there is a labor focused listening session or listening sessions. So we're open to ideas there. We have some flexibility on how we approach the listening sessions this year, and we'd like to take advantage of that. We would typically, in an in-person listening session, have someone to do sign language or translation services. So we want to figure out how we do that in this environment. We may do closed captioning or other things. So we have that on our radar as well. I think I'll stop there. I think those are some of the high-level considerations that we've identified, but I'm happy to hear feedback from the commission on how we should approach the listening sessions.
So I see that Tim Sullivan has his hand raised. Hi, Tim. And then Toby also has his hand raised, but why don't you go ahead, Tim?
Okay. Just a quick question. In the past, when we've had our listening sessions, for those who couldn't attend, we always had an opportunity where written comments and questions could be submitted. I'm assuming that will be part of the this process as we go forward as well, so that those who can't attend will have the opportunity to make comment and or ask questions.
Yes, that absolutely. And I think in addition to that, Tim, this being a virtual listening session, we can also record those and make those available to anybody afterwards who wasn't able to make the session.
Oh, I think that's so.
Thank you.
Go ahead, Toby.
Matt, I would urge you in kind of thinking through, I like your thinking on the listening sessions in terms of, in the COVID world, how to do it. But I wouldn't just limit it. I think that's going to be, I would plan to kind of, at a minimum, go be in a hybrid environment in the future. And I go big on thinking about how the listening sessions can be much more responsive to individuals or audiences or interactive, and really make the investment that this is really going to be the long-term approach. And there may be a hybrid. I'm not suggesting there's going to be nothing, but I think it really gets at a lot of the issues that we've seen over time, like, how do you reach the people on the islands? How do you reach the people in the Cape? How do you reach this really gets at it. And so think big and look at it as a long-term implementation. That would be my suggestion.
Yeah, that's a great comment, Toby. Thank you. And this will be one area of many where we're looking to kind of bring forward a number of these sorts of innovations, I guess, in a permanent way.
This is not a mandate approach. This is a new this is a new and better.
Other questions or comments, Madam Chair?
I don't see any.
Okay.
But I loved Toby's comment. I think he's spot on in terms of thinking about, how do we engage members, for the long term, and a hybrid approach, and finding a way to reach them, and the recordings. And I think that's all terrific. So.
I would just like to say something. I'm only waving because I can't find my little chat hand, hand.
Go ahead.
So I have to, sorry. So I just wanted to say that, don't forget Saturdays, don't forget a weekend day, even though it's a strange environment we're living in right now. But I like your idea of different, times of the day and different days and spreading it out over a couple of weeks. I want to also make sure that when people are like we did during a live session, when people have questions, that the questions are repeated for everyone and the response is that everyone can hear the response. So I am not sure where I stand on more focused sessions, because if you have a retiree session as an example, and only retirees log in, people who might think about retirement, 3 years hence, probably won't feel like coming, because we don't know who's interested in various sessions. So even with municipalities, because some people have a wide range of interests, so I'm not sure where I sit on that. I haven't had really time to think about it, but I just wanted to sort of state my concerns until I figure out what I really think. But I'm not sure. I appreciate that it might be a good idea, but maybe that could be part of the, maybe part of the survey, or just a questionnaire, just about how do people feel? How do the members feel about that? I'm not sure how I feel about that as a member of GIC and also on the commission. So I don't know if any one of my co-commissioners sort of what they think about that.
Well, I do think you make a good point, Bobby, because at many of the listening sessions, there are questions by our constituents about planning for retirement. And I do find, I think this has been reported by Paul many times, that the majority or a big part of the, the open enrollment health fairs, people come to learn about retirement, and the GIC is just a great resource for them. And so the listening sessions can help with that. So, I'm sure, Matt, you and your team will incorporate some of Bobby's comments. And, I just have always been very pleased with the degree of focus that the staff put on making sure they meet member needs. So I think you made some good points, Bobby.
Thank you. Thank you. Yeah, that's good thing. Good thoughts, Bobby. And to be honest, we raised this issue and started kicking it around, but we're not sure how we feel about it either. It's presents some different opportunities, but implications that we need to think through. Thank you. All right. If there's no further questions on engagement or listening sessions, we can move on to the next item in director's report.
Great. I think that's good.
I'll hand it over to Andrew to give a brief update on the amendments to our regulation process underway. Andrew?
Thank you. So following the commission's authorization to move forward with the amendments to the regulations in September, we began to circulate the amendments to stakeholders and solicit feedback. We set up an email address to receive testimony. We published and noticed a public meeting on October 9th that were held on November 10th. So it was in the newspaper, it was in the register, it was on our website, and we also circulated the notice out to stakeholders. We had 2 hearings on November 10th, one in the morning, one in the afternoon. I think the total attendance of non-GIC personnel between the two is about 6 or 7 people, 2 of which were from our plans. The first meeting, no one spoke. We had no testimony. I did, for each meeting, run through a PowerPoint where I presented every change and the explanation for it, and solicited feedback. At the second meeting, we had our only comment, which came from a consultant who wanted to know if we would consider doing an extra data. This was concerning municipal data that we provide to municipalities who might be thinking about leaving. She wanted to know if we would give an extra one after they've told us they were going to leave. So that was the only comment we had. We have received, as of this morning, no testimony or feedback in writing through any channel. The process now, we would plan to finalize the amendments and bring them back to you for the next commission meeting for a final vote. And then we will move to promulgate them with the Secretary of State's office. And if there are any questions, I'm happy to answer them.
See any, Andrew, unless Bobby, do you have a question?
Okay,
So
I think we can move on.
Yeah, I think we can move on, Andrew. Thank you.
All right. Thank you, Andrew. The next item on the list here is our coming office move. And I've asked Maureen Quinn, a project manager who helps us on a number of really critical operational issues within the office, to give a brief presentation of our office move. I think, as the commission will recall, we were slated to move from the Hurley building, which is due to be, I think, redeveloped entirely. We were slated to move in fiscal 22, but with the arrival of COVID-19, that has been accelerated a good deal. So we're actually deep into preparations to move our office from our current space at the Hurley building up to the McCormick building at 1 Ashburton on the 16th floor. It presents some real opportunities for us, particularly similar to what Toby said before about kind of bringing forward some of the positive developments I hate to call them positive developments of a pandemic, but learnings about how we've managed to survive and continue to operate, carry those things forward. So we're taking this opportunity to really reimagine what our physical footprint in the office looks like. And Maureen has been central to all of that planning and execution. So I wanted to hand it over to Maureen. We were having some challenge with her audio. If she's not able to do it, I will complete the story here. Maureen?
I think I'm all set. Thank you for this opportunity. I just wanted to report that we're having a really great cross-agency planning sessions with DCAM and TSS. Right now, the planning is centered around setting up an appropriate IT infrastructure for everyone with the new phone system that will support working remotely as well as working when we're, get back to the 16th floor. We're also focusing on refreshing the area to accommodate a new work style. And as such, we're making sure that we're all on the same playing field. So we had a tech deployment. So we're making sure that everyone has the same equipment so that they can do exactly what we're doing today. If anything, it's a thoughtful effort in terms of our planning, and that comes right from the top in terms of our making sure that everyone feels safe to come into the office to set up our next thing will to have people come in and get their personal belongings. But basically it's going well. We're focusing on the infrastructure, and the move probably won't be till after the current year, once we get 2020 behind us. And so that's really a high level. If there's any questions, feel free. But as I said, our focus is making sure that the environment is safe and we have all the appropriate PPE for people to come in. We're doing this very socially distanced and with a very regulated schedule. And to be mindful of everyone's situations. Any questions? I know that was very high level, but I think probably.
I have a question.
Hi, Bobby.
Hi, Maureen. How are you?
I'm great.
It's nice to see you.
It's wonderful.
So I have a question regarding the workspace, because I know some agencies started moving, before COVID, and certainly are thinking about it since it arrived on the scene, about the sort of drop-in workstation. So I'm curious if what the plans are, I guess, for the individual workspaces. Are you going to have cubes or a combination, or?
Great question. We're working with a number of different entities to try and find the best solution. And that initially, when we started, as you can imagine, it's a paradigm shift in terms of how we work now and how we will work in a socially distanced environment. So that's how we're trying to frame this, in terms of we're not going to be sitting next to someone. We're going to be sitting maybe a cube away, so that from a space planning exercise, it may look entirely inefficient, but we're not going to be able to be next to each other like we were. So those are the considerations in terms of also how do you conduct a meeting effectively. And I think that the whole idea of think big and look at the long term is how I couldn't have said it any better, is how we're trying to look at things. But in terms of seating, and we're doing this in a socially distanced way so that it's basically every other cube, and taking into consideration, we have HIPAA requirements involved in our information, and we also have we have operations people, so that we have some unique requirements that that DCAM is taking very seriously and accommodating. So I'd hate to say we have a total solution, because we're still working on that, but that is at the top of our list.
And I'll just chime in here too. One of the things that is central to our planning here is preserving an important role for telework as a permanent feature. And I will say that is we've heard that loudly and clearly from our staff, that this is not only in COVID, especially in COVID, it's important, but not only in COVID, that it's presented a variety of different positives for our staff to be able to work from home. Now, that said, we all know the challenges of exclusive telework. And what I've said is that we can effectively continue the machinery of the organization to do what we need to do. That can continue and has continued to function efficiently during COVID-19 and largely telework. But there are a variety of other types of work that are just hard to do from a completely virtual environment. So creative work, collaborative group work, long-term planning and strategic work. There's going to be a need to be in the office, for some substantial amount of time, but it's going to be, I think, for different things. And the default won't always be, you're in the office to do your job. There's a lot of considerations here. And Bobby, I'm sure you have this on your mind too, that remote work doesn't work for everybody, given their unique circumstance, whether it's the housing situation. I know myself, I've got 2 college kids remoting into their classes at home, and we've got a fairly tight space, so it's not ideal. So the way we're thinking about it is our space will have to look different. It'll have to have different features to it. We'll have to accommodate group meetings. So we're thinking like flexible group meeting type of space. In terms of like everybody having a seat and an assigned desk, that's probably not going to continue. But I think a sort of wide open, kind of pure hoteling type model, I'm not sure if that's entirely appropriate either. So I think the benefit for us is that we're moving while everyone will continue to work from home. So we have a little bit of runway to structure it after we get there, and take all these various considerations into account.
Thank you. Thanks very much.
I just want to know what the GIC meeting room will look like when we get back together, maybe in a long time, but just thinking ahead.
Yeah,
I'm sorry. I was just going to say it has to be pretty large if we're not going to be able to sit next to each other, since there are so many of us.
Yeah.
And to allow for the audience, it'll have to be huge.
But aligned with the theme that has come up already a few times in this meeting, there's probably a permanent role for a remote capability, particularly for those commission members who travel significant distances or have other commitments. I think it also opens up the possibility for us as a staff, but also as a commission, as we recruit talent. We can recruit talent from across the country now. We're not limited by geography in attracting talent for a variety of functions.
Okay, good. Let's keep moving. This is all good stuff.
All right.
Thanks, Maureen.
Thank you, Maureen. If there's no further questions, I'll turn it over to Denise for a brief update on life and long-term disability procurement and our dental and vision procurement. As always with these topics, I'll spare Andrew from interrupting to add the legal advice here, which is that these are ongoing procurements. So our ability to get too deep into details about them is very limited. So the update then will be pretty brief.
Yes, very brief. I see we're almost an hour in, so I will just let you know that these procurements are underway. And as Matt said when he was presenting the calendar, we will have the apparent successful bidders ready to recommend to you for the December meeting.
Okay, good. Good, thanks.
Great. That's how we get back on our time schedule, Denise. Thank you. So that concludes my extended director's report for this meeting. And I think the next item on the agenda is to proceed with a report out back to the commission on our stewardship meetings. So we do this, I think every year, or at least every year that I've been involved in GIC meetings. We've concluded our stewardship meetings with all of our major vendors, and they're a fantastic opportunity for us to talk about developments in the respective marketplaces, but also review performance of our vendors relative to their obligations to us. And they, for me, just as I don't think I can still quite call myself the new guy, but it's been a tremendous learning opportunity. And I want to thank the carriers. I hope I'm not stealing Denise's thunder here, but they put an enormous amount of effort and preparation into these meetings. We ask a lot of them, and they invest a lot of time even just in the presentation itself. So kudos to the carriers for their excellent work, and I'll hand it over to Denise for what our takeaways are.
Yeah, next slide, Janine. So I'll keep this brief and just sort of touch on the highlights. You'll get more detail on the data relating to COVID when Margaret speaks, but I will tell you that the plans, most of them were running really hot before COVID hit. And by hot, I mean the trend was really running very high. With COVID, things kind of fell off a cliff, and utilization dropped, as we all know. But unit costs in the meantime continue to increase, and we're seeing that play out in particular with high cost claimants. The number of high cost claimants, the severity of their conditions as they're reported, continue to accelerate. And that's true through the first quarter of this fiscal year. We received reports from a number of carriers already, and that trend is continuing. Specialty drugs are really an area of focus for us. We are seeing double-digit increases in many cases, and by double-digit, I mean 30, 40, and 50% year-over-year increases in the cost of specialty drugs. And that's an area, obviously, of a lot of concern. Engagement in health plan programs such as care management and disease management remains low. That's nothing new. Another headline that I think we're all aware of at this point is that telehealth really blossomed during the pandemic. And this is true in particular with behavioral health. And Margaret will share some data on that as well when we get to her presentation. In the meantime, EAP utilization remains very low. So while members are turning to reaching out to behavioral health providers in a very positive way through telehealth, they are not looking to the EAP for the most part for that kind of support. Next slide, Janine. So some of the trends we'll dig into. I already hit on a few of these points. High cost claimants are really where we're seeing a lot of the trend develop. As I said, the number of high cost claimants is accelerating, the severity of their conditions as they're reported. Cancer is the most prevalent condition. That's not really new, but the cost associated with treating cancer, and a lot of that is driven by the rising costs in specialty drugs. We're seeing unit cost increases continue to accelerate both with inpatient and outpatient facility charges. And unfortunately, C-section rates remain high, and that will be an area of focus with the plans in the coming year.
Hey, Denise?
Yeah.
How did you guys separate out high cost claimants? Like, what was the cutoff? How did you?
Yeah, the baseline is any claimant with claims of $100,000 or more.
Okay. And so do you have actual numbers? So how many?
We do. I don't have them off the top of my head. I can share them. We can share them afterwards, but yes, we do have numbers.
Okay,
Yep.
thanks.
Okay. Bobby, you're on mute.
Yeah, thank you. Sorry. I was curious that $100,000 measure. So are we talking about primarily in-network costs?
Yes, for the most part. Yeah.
Okay. And could I ask you if you have any idea if EAP, like what the reason, what possible reasons, I guess, is it lower? First of all, is it lower than it was, let's say, last year? EAP, interest, access, and what do you think is going on with that? Like,
it's just too new.
Yeah.
So I would say EAP utilization is pretty much flat. There, it's not lower, it's not higher, noticeably. It's not unusual that the EAP isn't getting much traction. That's pretty common. Most employers who offer EAPs find that the uptake is just not as high as they would hope. I think the good news, as I said, is that people are utilization of behavioral health benefits is rising. And that's really good news. So people are reaching out for help and support during this pandemic. And they're doing that more through telehealth, which is great.
I will say, Bobby, that and we talked a little bit about this, I believe, in the September meeting, but one would certainly have expected that EAP utilization would have at least spiked a little, and we just really didn't see that. And it does mean that we need to dig into why that is the case and evaluate what is the best solution to support our members in this way. I think a lot of folks look at EAP as an opportunity for almost like a complement to behavioral health services that you can get just through your healthcare providers and provided by the health plans. I'm not sure if that's where I would look to an EAP to provide value. And there's a lot of work that we need to do to rethink EAP. I think there's a case to be made, particularly given the trends that Denise notes about telehealth for behavioral health really spiking. And I think that's here to stay. In order to have integrated treatment for behavioral health and non-behavioral health, knowing that they are so integrally linked, I see the role of behavioral health services through the health plans and sort of therapeutic services in the behavioral health space through the health plans as being really the core of our support for our members' behavioral health needs. The EAP can be complementary in that regard, but at very least, you need to think of those in the same strategic conversation. How is the EAP adding value to the core behavioral health benefit and not just duplicating in a way that's not effective? So we've got a lot of thinking to do about the EAP.
Right. And maybe it's just, is there value? Like I'm thinking, times have changed, things have changed. Perhaps people where years ago, like let's say 10 years ago, people were encouraged by the employer to seek, some sort of behavioral health, let's say, some sort of therapy or, enroll in some sort of program. And, I think people are maybe less afraid of engaging behavioral health programs directly. And maybe because people are becoming more knowledgeable about it or less afraid, I think because EAP is sort of still where it is, and I don't necessarily mean our program, I think in general, EAP programs have been sort of stagnant. They operate the same way they did years ago, except maybe now they're virtual, but that hasn't changed, and everything else like has, I think. And maybe we just need to rethink, or, you know, like, is there value for that even, or a different way of looking at it?
Yeah, thank you for that, Bobby. That's really helpful. And I think we need to remind people that the EAP is not free. I mean, there's a cost to the GIC to provide it. So we want to bring that lens to that service and that procurement that we bring to any expenditure of our limited resources.
Yeah. I see that Patty and Anna have their hands up. So Patty, why don't you go first, and then Anna, go ahead and make your comments or ask your questions.
Thank you, Valerie. Denise, I wanted to ask about the unit cost increases that we're seeing on the inpatient and the outpatient charges.
Yeah.
What I'm wondering about is, I know you mentioned on the previous slide, that's being driven by an increase in the frequency and the severity of the claims. And I'm just wondering if the payers have been able to sort of identify if that's tied to deferred care claims, like, you know, people not going to get the care that they need, and therefore, you know, we're starting to see, you know, the severity of those claims jump up as a result, or if it's too early to know any of that yet.
It's not. So first, let me just say, it's not the frequency of the claim. It's the cost associated with the facility and the diagnosis that's assigned to the claim. So I don't think we're seeing, this is cancer treatment. This is musculoskeletal. There's nothing, I don't think we're seeing anything that is an effect of deferred care. These are admissions that, you know, I think we would have seen no matter what. So it's just my judgment, but I don't think this is the result of deferred care. And that trend is continuing, as I said, through the first quarter of this fiscal year.
Yeah, and just to emphasize that point, I mean, these were trends that we saw previous to COVID as well. These were drivers that we saw in our carriers' Q3 performance previous to March.
Okay, thank you.
And then go ahead, Anna.
Thanks. This is really a great overview of the trends. I wanted to ask about the benefit design associated with the behavioral health via telehealth. And in particular, like thinking, are you guys looking at just sort of this response to telehealth in behavioral health is something we are seeing broadly. So, you know, it makes sense we're seeing it, you know, within our members too. And how are these visits being treated in the benefit design? And then how are you guys, have you started thinking about that going forward? Because if it's a more temporary thing, then we might see the demand, you know, fall off. But is it just sort of parity? Has it been treated the same by the carriers with an in-person visit thus far?
Yes, it has been treated the same. It is treated the same. And we are thinking ahead as to how we may take advantage of this opportunity that the pandemic has delivered to us. And while we're seeing the telehealth visits drop off for other services, behavioral health continues to be pretty high. So it seems to be sticky as well. So yeah, it's something we're really pleased about and hoping to take advantage of going forward.
Yeah, thank you. And if I can just chime in too, there's a lot of issues here. We have some temporary measures put in place through executive actions to ensure that, you know, telehealth services are paid at the same level as in-person visits. We, as a purchaser, implemented a requirement at the start of COVID that cost sharing for all telehealth services was waived. That probably is not sustainable or advisable as a permanent feature, but it does, particularly as it relates to behavioral health, it does raise the question as to whether there's plan design features and cost sharing features that can be tweaked to take advantage of this development. I will say, in addition to that, though, there, at least in my mind, would be open questions about the efficacy of providing any services, really, but certainly behavioral health services among them via telehealth as kind of a permanent feature. So I think it will be interesting to see or to learn what the evidence suggests there. It may not be for every provider. It may not be for every patient. In fact, there was some data that the sort of qualitative data presented by the Health Policy Commission through a survey yesterday, or that was presented yesterday, that suggests counterintuitively that younger patients, I don't think this was specific to behavioral health, that younger patients have more concerns about services delivered via telehealth, that there may be some reluctance around telehealth, particularly for behavioral health. So it's just a survey. It's I think the response to the survey was pretty modest, but it raised some interesting questions that I think we need to spend some time on about what is the role, the appropriate role of telehealth after COVID? Where is it most effective? And then how can we then adjust our approach to benefit design to kind of drive value there?
No, I think this is good conversation. I mean, I think commissioners have historically asked for, more data on how we're supporting our members from a behavioral health perspective. And so it will be interesting to see if access is improved, if providers in the behavioral health network feel like they are supported, if telehealth helps those providers feel, like they've got a bump in support, because they may have better control over their schedules. I think those are all things that hopefully we can get some quantitative data either with our membership or just in general from, health plans and, the Health Policy Commission's looking at that. I'm sure there's a lot of people looking at that. So collecting that data and sharing with it, and it sounds like you're already thinking about open enrollment and new benefit design, helping our members there. So all good.
Okay. Anyone else?
Yep.
See anybody else?
Oh, Denise,
Yeah,
sorry.
hi.
I know you can't, I have no idea where it disappeared to, but sorry. I just have a quick question, Denise, regarding the number of providers. Have you seen an increase in the number, since COVID? Is there, because surprisingly, I've not heard any complaints from people. I've actually heard that people are connecting with providers. So I'm just curious if you know the answer to that, and also whether we are talking about in-network providers, like has there been a shift where perhaps more providers are accepting our insurance?
So I don't have the specific data, Bobby, but I do know that the plans are constantly recruiting. And we did have conversations, I think, with all of the plans about their reimbursement rates. And they're all now have adjusted their reimbursement rates for behavioral health providers. So I think we're in a much better position than we were a year ago. So given the data that Margaret will share in the next section, I think you'll be pleased to see that it seems that people are getting the help that they need.
Yeah, and I will just add to that we heard, so as Denise mentioned, it was a specific issue that we raised with our health plans during the stewardship meetings. And anecdotally, what we hear is that there has been fairly wide a trend across the carriers that they are adding providers to the behavioral health networks. And as Denise said, it's largely, I think, attributable to, the increase in rates that we've been pressing them on. But I want to note that it's one of the areas of follow-up with the carriers from the stewardship meetings to put some real data around that question. So we expect to have more specific findings to report to you at a future meeting.
Okay, next slide, Janine. I'm going to speed through this a little bit because we only have, looks like 50 minutes left. Nothing really noteworthy here. I think the major conditions are the ones that we see year over year. Cancer, maternity, diabetes, musculoskeletal, and behavioral health are really the top conditions that we consistently see. As I mentioned before, care management programs, there's very low engagement, although we have some promising early engagement data from a pilot program that we launched with Tufts through an organization called Onduo for people with type 2 diabetes. And we're seeing some early promising results there. And we have a new maternity support program recently launched through Harvard called OPIA. Next slide, Janine. Again, I'll keep this light because we're going to get into a lot of detail in the next section. There has been, as Patty noted, some deferred care, general office visits, urgent care, emergency room care is down, preventive exams, but we did see that trend start to reverse itself starting in June. We'll see what happens with this second or third wave that we're in now. We did see, for the most part, decreased risk scores, and we attribute that to the fact that there were fewer claims that were being submitted. We already mentioned telehealth and the huge increase in utilization there. And with respect to behavioral health, our most common diagnoses are depression and anxiety. Any questions? If not, I'll turn it over to Margaret. Next slide, Janine.
So before Margaret chimes in, I just want to say a couple of words. So we did, at our last meeting, as I noted, presented some early findings around COVID, but I think the commission challenged us to take this set of questions back and to provide some real data on the impact of COVID on our membership. So Margaret has taken up that challenge, and this is kind of our first presentation back to you on that question. I will note that we're asking her to do that in the midst still of our transition away from our prior vendor to Milliman as a data warehouse vendor. So we have really high hopes for the capabilities of our data warehouse going forward. And so here I think we're providing you a little bit of a teaser of what our data can do in answering questions that we all have. And we're interested in evolving our COVID reporting to you over the coming months. So as you listen to Margaret's presentation and have thoughts on what more you would like to see in this area, we'd welcome the feedback. And I do just want to note that I've referred to it already, the Health Policy Commission's reporting around COVID data. Fascinating stuff. And so if folks have not had an opportunity to see their meeting yesterday where they walked through this data, it's worth a look. And I should also note their work with the Center for Health Information and Analysis to pull together that data. There are some really interesting findings. I'll turn it over to Margaret, please.
Thanks, Matt. And just one more agency to turn your attention to is that the Attorney General's Office just released a fantastic report specific to health disparities. And I think there are a lot of really important learnings to take from that. All right, next slide. Thank you. This presentation, as Matt said, is intended to provide really a high-level overview of what's going on with the GIC member populations in terms of COVID infection and healthcare utilization a little more broadly. Again, as Matt mentioned, I'm developing a regular COVID reporting for the commission. So questions are going to help me. It's going to help me know what's interesting to you to hear more about. So please chime in with those. And again, I think this deck really, it's a good high-level overview just to start as a starting point, a grounding for what's going on with our membership. And then now, because I'm an analyst, I have to jump into a few terms, caveats, and parameters just to make sure we're all on the same page. I want to make sure everyone understands that this report looks at health claims data only for services received between March and June. So if you recall, early in the pandemic, people with mild symptoms were encouraged to stay home unless their symptoms worsened, which means that I would expect that someone with a milder case who didn't go in for healthcare wouldn't be recorded because there was no claim that would have been submitted. So the point in me saying that is that this is likely an understatement of COVID in our population. Really, this is confirmed positive COVID diagnoses in the GIC population, which is a mouthful, but it's important to understand essentially that this would be an understatement of COVID. Secondly, the report runs between March and June and stops at June because by the nature of claims data, there's always about a 3-month lag in getting all of the data in. So that's why I haven't been able to present on a time period for the commission before. So this was the first time that I've really had what I felt was a complete set of data that would actually paint a picture of what's going on. And finally, on my analyst points, I want to point out that our baseline for all of these slides is, we're looking at utilization in March and June of 2020. The baseline, the comparator is March through June 2019. So if you're wondering what I'm calling flat utilization, that would be the same utilization as we saw in 2019. So with these caveats behind us, I'd like to turn everyone's attention to the map on the title page that I'm pretty excited about. It was created by my teammate, Janine Dewar, who took data that I pulled from the data warehouse on COVID infections in our population and at the zip code and city level. And she was able to create this map of COVID in our membership population from the time period, March through June. So it gives you a sense of the magnitude and of the geographic dispersion. It's an excellent slide.
Could I just ask quick clarifying? Yeah. Sorry, thank you. Is this all the members or just?
No, yes, that's an important, these are the Massachusetts members. It was a Massachusetts zip code city based. Oh, no. Now that I'm thinking about it, I think I did pull all of the data and zoomed in on Massachusetts. So we saw a lot in Florida. We have members all over the country, but that was a bit of a mess of a graphic. And I think this just graphically looked cleaner for the presentation. Yeah.
And do you know, are these mapped based on just the individual cases or mapped based on the geographic dispersion of members and within those, clumps of membership who had COVID?
So this was mapped based on how many claimants, so what claim had to be submitted, how many claimants in a zip code. And then if there were, as you see on the bottom right of this map, we've got we've got a key here. And so the smaller, the one dot is smaller, the over 100 is a much larger dot. I'm not sure that answered your question, Valerie.
So I'll try it another way. I'm probably not asking it well. Is this representative of our population?
A very good question. I think so. Roughly, one of my on my to-do list is to pull all of the membership, zip code, and city data and run that through the same program, or actually ask Janine to run it through the same program and make me the same map. But yeah,
so I'm very excited about this data, and nice work for you and your team. Patty has a question. Go ahead, Patty.
There we go. I'm just curious to understand, this is GIC membership and not just the subscribers?
Entire membership, not just subscribers. That's right. And that's true for the whole report. Yeah, it's a good analyst caveat. Thank you.
And if I could ask you, Margaret, so is the membership like based on the residents in Massachusetts, based on where our members are currently living? Or
so based on where members are living. We also have the capability of creating this map based on work site, which I think could be valuable to us as well.
Okay, so if we're talking about, let's say, someone who has a child in college out of state, but submits a claim,
yes,
is that considered like where does that fit in this map?
Yep, good question. So they would be, so the college student would be a member, and if they were in Connecticut, they might be one of those dots in Connecticut. But if they were, we have a larger map as well that has everybody with a positive COVID diagnosis across our membership. So I don't want you to think that I can only report on Massachusetts members or people who work in Massachusetts. I have all of the data for across the country, or wherever a member would live, actually. Yeah.
Nice work. Let's keep moving.
Yeah.
Good stuff.
Next slide, please. All right, starting with demographics. What we see in this slide, here we have the distribution of COVID by age and gender in our population. There are not a lot of surprises here. These numbers generally fall where we'd expect, given the makeup of our membership. I think it was of note to me initially that 57% of the positive diagnoses were with women, until I pulled the data showing that 54% of our total membership is female. So I think there's a little bit more with our female members than our male, but I think I don't think enough to say that, women are being hit significantly harder in our membership. I think that there is a really important conversation, as we've seen through this pandemic, that is, in terms of demographics, is specific to race ethnicity, and it's a gaping hole we have right now in our data reporting. We are working hard to bring in race ethnicity data. I'm very optimistic that we will get it, but we don't currently have it, and that's kind of hard for me as an analyst, as we know a lot of the story centers around race ethnicity. I can tell you that our membership absolute positive diagnosis numbers are disproportionately high in communities that we know have a large minority population, such as Dorchester, Chelsea, and Lawrence. But I can't yet identify members specifically by race ethnicity. But I hope that very shortly I'll be able to report on that to the commission. I think it's it is one of the central stories of this pandemic, and we'd be remiss.
And Margaret, is the reason why we can't report is because our health plans aren't submitting it through the data warehouse, or?
I think the health plans are also struggling to get the race ethnicity data. They have what is mediated through a claim, which is not necessarily going to be race ethnicity. I know where the race ethnicity data for our population is. It's just a matter of kind of vetting all of the concerns about releasing it to us and making sure everyone, understands we're using it responsibly. And so that's the process we're in.
Yeah, no, thank you.
Yeah.
Margaret, if I could just ask you, when I'm looking at this, and I'm sure we've all read, many articles regarding race and ethnicity as it relates to COVID, but given the higher percentage of women, I'm also very curious as to, and I don't know if you could ever get this, but the job classifications or the job, the positions in which people work, if it were possible to get that data as well.
I am optimistic, but I am always optimistic. So let me do some due diligence and get back to you. I think that's a fantastic idea. That's a great way to report on this data. So thank you for that suggestion.
I think the other takeaway from this slide is just a higher level takeaway that we have, at least as of the reporting period, and 4,557 members, which is about 1% of our membership, and also an important takeaway.
And then I have to jump in with the analyst caveat.
Yes, I knew it was coming.
And say yes, but these are the positive confirmed diagnoses, so it's not capturing everyone. There are also a number of members who would fit into a bucket that would be suspected COVID diagnoses, and there was no clear way for me to standardize that across all of the carriers, and so that's why that's not captured in this report. Yeah.
Madam Chair.
Yes, go ahead, Jane.
I have to say that I am just dismayed that we don't have data that on race and ethnicity. It's almost painful for me to acknowledge that. But it's also a broader issue because so many times data is not available to give us information about the health and well-being of Black and Latinx Americans. So I guess one of the things I want to know is how soon will we have that information? I was reading just recently, as perhaps so many of you are, especially with the murder of George Floyd, data about lifespan. And here in the greater Boston, where we have the city of Ed and Med, there is a report that's easily retrievable on the internet that shows that the lifespan of Black people, the lifespan of persons who live in Back Bay is 92 years of age. And the lifespan of people who live in Roxbury is 59 years of age. I suppose the good news is that the data is available that allows us to see that stark disparity. But it also raises, as you can imagine, a host of questions about why there is that kind of gross disparity 3 blocks away. And so I just want to register my dismay that we don't have that information, that we have this information about women and how they may account for a certain percentage, but not about members of racial and ethnic groups. I just find that appalling.
Yeah, I just want to acknowledge that, Jane, and I think where I am optimistic here is that there is a broad acknowledgement of this gaping hole in Massachusetts specifically. Margaret noted the Attorney General's report on health disparities, and with a flavor of COVID-19, but it's not only about COVID-19. Some really helpful recommendations there. The Health Policy Commission, as I noted, working with CHIA, has identified this as a really top strategic priority. And I want you to hear it from me that we are as well. And we will proceed on this issue really locked arm in arm with our colleagues in state government. I think where I think the GIC and the Commonwealth as an employer generally, as that, we have I think an opportunity that perhaps other employers may not have, or a path to securing some of this data that may be, we may be able to get there before others. But as you note, Jane, this is it's a broad system-wide issue, and what it leaves us as a Commonwealth, where it leaves us is to do our best to sort of create proxies and workarounds to try to, in a very imperfect way, get at these issues. You've noted kind of communities of residents, adjacent as they are, with starkly different outcomes. And those are just based on community of residents. That's sort of, it's like you say, it's a proxy, but we need to do a much better job of capturing this data. I fear for what it shows, and I know it's going to be jaw-dropping when we see it. But I do want you to know that it's a high priority for us, as Margaret has noted here, on the data side.
Yeah, no, and thanks, Matt. And I echo your commitment. And I would ask, when we are interacting with our health plans, for them to give an update, because it's really in the collection of data for the claims that can identify this, right? So some claims may not require you to identify this. I know in the pharmacy world, there's just no place, at least when I ran pharmacies, where you could register, race. We didn't collect it. We didn't need it to collect payment. And, so it wasn't an omission by any other reason, but, that's how we got paid. So how are the insurance companies mandating to providers that in order to get paid, this information has to be collected?
Yeah, that's a good point. And I will note that, and Denise may have more to add to this, but it is also an area, a line of questioning that we pursued with the carriers during the stewardship meetings.
Oh, good.
And while it involves a lot of imputing information, as I mentioned, there was some really creative thinking on the part of several of the carriers. I know Harvard Pilgrim had a particularly thoughtful dive into this set of issues. So that conversation has begun and will continue with the carriers.
Good. No, thank you. And thank you, Jane, for raising it. It's an important one that we need to continue to, have openness to addressing. So thank you. All right, let's move on. This is good stuff.
Okay, next slide, please, Janine. All right, we're looking here at inpatient utilization, essentially hospital services. The story here is consistent with what we're seeing broadly in the Commonwealth, and that's that hospital utilization dropped sharply in March and April, but returned pretty much to baseline, or even a little bit above in June. While it is a good thing for the health of our members that care is once again returning and people are accessing care, And it is good for our hospitals that they are treating patients. There's still here a really important question to ask when looking at this aggregate data. That question is with any aggregate data is who is receiving this and who is deferring care. Are only the highest resources returning to the highest resource returning to the system, or are those returning representative of the population as we'd hoped? And this question, I think, is even more pressing with the next slide, which is outpatient care. With outpatient care, we see an even more dramatic drop in services. To a large extent, this is what we'd expect, as hospital care shown on the previous slide is more acute and pressing. As for outpatient care, a statewide mandate to administer elective care was in place in the pandemic. As with the previous slide depicting inpatient care, we see utilization bottom out in April and largely return in June, though it's still 12% below the baseline of June 2019. So we see this return to baseline. Again, we need to ask who is returning to receive outpatient care and look at this utilization data by race, ethnicity, and determine who is returning to care among those needing maintenance for chronic conditions like diabetes, which we know has a high prevalence in the Black community nationally, and I would imagine in our population as well. Next slide, please. All right, this is a deeper dive into outpatient utilization. We are able to aggregate that data from the last slide. We're able to disaggregate it in terms of service categories and look more closely at what's going on with specific types of outpatient utilization, such as physician office visits, ED utilization, and psychotherapy. So this graph here depicts the percentage change in utilization for ED, which here is in orange, office visits in blue, and psychotherapy in gray. The baseline in this case is 0, meaning 0 would indicate that the percent change in utilization from there was a 0% utilization in change in utilization from 2019 to 2020. So, you know, we see the blue line far below our 0 baseline, and the orange line even farther below. If there's a good story, it's that therapy is above that 0 baseline. I will say that the rest of the data for Massachusetts more broadly looks a lot like this. Physician visits and ED utilization dropped markedly, though it certainly seems to be heading back to baseline in June. Regarding psychotherapy, we will see later in the presentation that this uptick can be attributed largely to telehealth, though I also want to mention that our carriers are working hard to expand their behavioral health networks. And during such a stressful time, I'm really relieved to see that people are able to access this care. And then again, we've got to get back to the question of who in our membership is able to access this care. Next slide, please. Okay, I find this slide a bit comical, really. It's a dramatic representation of the shift towards adoption of telehealth utilization. Really, that first column, if you can even call it a column, it's more of a line, is a near 0 number, 552 telehealth visits were provided in 2019, March through June. We see an incredible jump for the current time period. Again, I think this jump in utilization, dramatic, and also really good news. I think a lot of provider systems worked really hard to stand up telehealth capabilities during the pandemic. So I was also able to disaggregate this data by service category again, so you can get a sense of what services were being provided through telehealth. And that's the next slide. So really over 90% of the telehealth visits were either office visits or therapy. I think again with therapy, this is a really good story. I think utilization and increased utilization in any way is always a positive. Is always a positive thing for therapy, whether it be telehealth, video health, or in person. And I would say back to that slide where we saw the therapy over the 0% baseline data. Almost a quarter of those psychotherapy visits were conducted through telehealth, and so that was really driving the increased utilization year over year. With that, I'd like to take any questions or any comments on what you would like to see in the future too. Would be very much appreciated.
I don't see any questions from our commissioners. I have one question. It might be a little bit off topic. Are we seeing any kind of changes from a regulatory perspective in terms of practitioners being able to deliver healthcare, across state lines? Because many times, I think there are requirements that if, and it's state by state, if you're in the state of Massachusetts, you have to be licensed to support, not teletherapy, but psychiatry or psychotherapy to different states. And, I'm just thinking about how do we broaden our network of providers if there's low utilization for some provider in Kansas, can they be in our network so that they can give access for behavioral care to our members? And I don't even know if it's useful, but just reflecting on members who have such a hard time getting access. If we are here to stay with telehealth, what are the regulations? And should we be trying to ensure that we're supporting those regulations to open up access to some degree?
I was on mute. It's a great question, and I know it's not a new question. When I was at the Division of Insurance, there was a number of, actually I think it was before I was at the division, there were a number of meetings or listening sessions that they held around telehealth, and this was certainly one of those issues. I suspect that there will be a pretty robust policy dialogue going forward after COVID around telehealth. And this will be one of those issues. I'm not aware of, we'll take your specific question back as to whether there are, whether there were regulatory measures put in place during COVID or otherwise that relate to that question.
All right, let's keep going. Thanks.
All right, so the last section here is the fairly standard budget update from our CFO, Jim Rust. Jim.
Hi, everyone. Good to see you all. This is a pretty standard update, so I'll move through it fairly quickly. It's more for your information as you peruse the deck, and of course, you can always follow up with questions off cycle with the meeting if you have any. So, next slide, please. Matt mentioned most of this, as did Denise and Margaret, but we're operating under an interim budget. The funding is sufficient to support our operations. I think that's the important thing for you all to know. Claims payments continue to rise as members receive both planned and deferred care. And we're seeing that upward trend continue between what we call the reopening level of June and the normal level, which would be pre-COVID. We're right in that spot between those two things, trending more towards the normal level. Next slide, please. In terms of COVID claims volume updates, in FY21 so far, we've spent $41.6 million on COVID claims. In FY20, we spent about 43.4. Those numbers move around a little bit as coding changes with the health plans, but it gives you a good sense of how much our spending has been. Next slide, please. I think this is the slide that's worth looking at. It shows the effect of COVID on the claims. I've shown this slide before. The red line is where we normally would be more or less on average, and you can see there's a lot of volatility in the claim spending volume, but there's a trend line there that clearly is trending upwards, and we would expect that to continue, assuming that the economy doesn't have to be shut down again in any way over the course of the winter. Next slide, please. These slides are purely informational that you've seen before. We think it's important that you see what we pay the vendors and how much we've paid them. So this is the state share of claims and payments over the first 4 months of the year. Nothing surprising here at all. As we're in an interim budget, but if this interim budget were to become our budget, we're trending pretty much right on the budget. Next slide, please. And this is the mirror image of that, which is the enrollee employee share of the same spending. Next slide. Normally, as you may recall, I show you a lot of line graphs. This is very simple line graphs. This is just the spending pattern. And actually, in the last couple of days, I don't have a graph for you, but Catherine Moore, our budget director, has done some analysis to see where the spending is compared to last year, if we control for timing and inflation and whatnot. And it's pretty much the same shape, which is what we would expect, because last year at this time, we hadn't been in COVID yet. But October spending went down a bit, and that's mostly because of pharmacy rebates, a little bit on volume, but October is a big pharmacy rebate month, and that affects our spending, but the number of claims is still about the same, trending in the same direction. Next slide, please. And as I said, I thought I would go through this fairly quickly. Again, I'm open to any questions, but this is the total in state spending, more as an FYI for the commission, so they know where we are on the year. Normally this would be marked to a budget, but again, we're in an interim budget situation right now. As Matt mentioned, we expect that could change soon, and then we'll start marking this to budget month to month and year to year as we normally do. So that was fast as usual. It's kind of a normal month for me, but I'm happy to answer any questions, and there'll be more information to come, of course, in the next meeting once the budget is set.
Yes. No, I don't see any questions, Jim, so thank you.
You're welcome.
So I'll turn it back over to you, Matt.
Yeah. The next item on the agenda is our last item, and it's any other business, new business that folks want to raise for us to consider for future meetings.
Are you looking for content or dates?
No. Just it's our last item. If you know, and if there's any other business to raise, and that's.
Oh, I see.
We typically don't have it, but I see Toby's got his hand.
Just a question, not new business, but seems like a good time. You mentioned earlier in your presentation that the conjoint study, which you've talked about in the past, and it struck me as a very important thing, had been pushed off a month or 2 months. I couldn't remember what you said. The question I have is, and I thought that was a fairly, at least my recollection, it was a fairly very important input into our next procurement process to really, get at what the various needs and the perspectives are of the stakeholders. Have we kind of in any way jeopardized the timing of getting the great input for that that procurement cycle, or where does the timing stand?
So I would say we've pushed it off a few months into the early part of 2021. Mm-hmm. I would say that my feeling is the same as you've expressed. It's a really important tool for us to gather information from our members about their preferences and plan design. What I wanted to make sure that we're doing is designing that survey in a way that is very transparent and thoughtful about the factors that we are gathering information on. So in particular, what are the list of features to a plan that we want to gather data on from our members, but more than anything, I want those who we're going to rely on to participate and to return the surveys, to have confidence that we're doing it in a way that they understand and that they, can get behind and promote. And so in my judgment, I think taking a little bit more time to do that was time well spent. And it allows us to have, I think, more general stakeholder dialogue of a more general nature about the coming procurement without sort of leading with our member survey. So in some respects, it's a little adjustment of sequence and timing, but I wouldn't want it to be taken as anything as a reflection on its importance as a tool for us going into procurement. And I don't think we're jeopardizing that with this adjustment.
Yeah.
Okay.
I think it's a good question, Toby. And, Matt, I know you've expressed to me a sense of urgency to be able to have the data you need to set us up for the next procurement, because, we do need to have transparency on what the issues are and if there's, and to what degree there's willingness to bend this curve of increasing costs to our constituents, but also increasing costs to the state without, apparent data that supports better outcomes or, healthier populations. So, this next procurement's critical. I think we need, and I'm confident that we're going to have all the support of the commissioners to be upfront about where they're willing to make changes so that we can bend the curve and see that measurable impact, and where not. So this conjoint survey is important. I just encourage you to continue, Matt, to have a sense of urgency to tackle the survey so we can tackle issues and have a path forward for the new procurement in a thoughtful way.
Thank you, Valerie. We certainly will.
So we see the dates in front of us. Anything else from the commissioners before we close?
If I could just, sorry, if I could just add regarding the survey. I mean, the procurement is not imminent, right? It's not for FY21, or for 22. And so I think it's important there. Yes, there is sense of urgency so we can, talk about the various issues, but I also think we need to be really measured and consider sort of every possible aspect, because we have learned much, particularly during COVID, and a lot of the issues, and Jane spoke to some of those earlier, as did Margaret. And so I think we want to be very cautious in rolling out this survey, that we want to make sure that it captures all the information that is necessary to go forward with what might be a different procurement.
Yeah, no, Bobby, totally agree. Let's make sure we get all the information and be as thoughtful as possible, but not, just continue to delay until we, get perfection. Let's not let progress be stymied by perfection. So, I just don't want to run out of time and then, not have a real aggressive procurement that can make a difference to the spend, but not impact quality.
Right. So I think that we're all aware of the timing, but this is what may be, right, a 5-year procurement, right? It's 3, and usually it's 5 years in reality, right. And so this is going to be a very, very important and perhaps different procurement. And there is no delay. I think it's about being measured and being cautious and including all of our membership, which and encouraging people to take that survey, right? So we can gather data, because typically the percentage of people, taking the survey and submitting it is, not that high. And so we also have to make sure that we have high enrollment in that survey.
No, absolutely. It's just, let's make sure we give the staff enough time to really make a difference with the procurement. And that's, I think we're aligned, Bobby. We're saying it in different ways, but let's just not delay to a point that we don't give staff the time to actually execute on the full procurement, because we know how complicated that process is, and they want to stay in full compliance. So all good comments. Anything else we need to be talking about? So at this point, I know I'm gifted in the authority to adjourn the meeting without a motion to approve. I want to thank everybody as we come into the Thanksgiving season. I know it's a different Thanksgiving season. We heard about the impact of COVID-19 on our members, so let's all do our part. And I want to wish you a very happy Thanksgiving. I, for one, am very grateful that I live in the state of Massachusetts, and I too mirror Matt's opening sentiments. I'd like to thank our government and our governor in particular, and all his staff and his administration, because we are so fortunate to be with his leadership and their leadership compared to other states, and we see it on the news every single day. And I'm really appreciative to be able to participate at the GIC to do my part. So thank you, everybody. Meeting is adjourned. Have a wonderful holiday, and we'll see you in December.
Thank you.
Thank you all.
Thanks very much.
Bye.
Thank you.
Have a
Thank
nice
you.